Thank you very much for inviting me. It's nice to see Dr. Shah, who I knew when I was doing my DM course. Milan was the first person who taught me cardiology, and Ajay, who worked in CEDARS together. Thank you very much for inviting me. This is a very interesting topic. The whole field of cardiology, there's a new term called structural heart disease. 5 years ago, when we attended all these conferences, it never existed. I'm sure if I come back next year, if I'm going to come at all, this will become no more a novelty, and it will probably become standard of care in India. 2 years ago when I came here, people thought it was just a myth. Now it's a reality, and tomorrow it's going to be a practice. Percutaneous dialysis, we don't have much of time, but I just go through just all the things we know about it. Lessons have been learned from cardiac surgeons, and combining our successes with percutaneous coronary interventions, valvuloplasty, and understanding the structure of the heart by imaging, we think that valve repair or replacement is not just a dream, but a reality. And like all interventionist cardiologists, we have this credo: anything that cardiac surgeons can do open, we can do it percutaneously. So we decided to embark now on the valves, and the scope is quite real. We can fix right ventricular outflow tract obstructions and regurgitations, especially blocked conduits, very important in pediatric patients. Aortic stenosis, which is a disease of the elderly, and as patients grow older, surviving all their coronary disease, you're left with aortic stenosis. And finally, which is my special interest, is mitral regurgitation. We learned mitral valvuloplasty as a true success story. India was one of the places where it started, and we've gone to the next step, that we actually can now fix leaking valves too. So going through, these are just the three topics that we're going to talk about: pulmonic valve replacement, aortic valve replacement, and mitral valve repair. First, the pulmonic valve, I'm saying it first because that was the first valve ever implanted in a human being. There are two such technologies available. This is the Melody valve, which is basically a jugular vein of a cow, which is mounted on a platinum stent and specially crimped onto a balloon, and sizes between 18 millimeters to 22 millimeters. It is advanced through the right femoral vein across a conduit, and this is primarily used for treating of complex conduit restenosis or regurgitation. And this is basically a balloon technology, and you can see over here, this is the first patient, actually this is the first patient to ever receive a percutaneous valve replacement. And he had two operations before for tetralogy fellow with a complex conduit failure, and this third procedure was an actual percutaneous valve, pulmonic valve placement with a stent. And this is Bonhoeffer, who actually did the procedure and who is the inventor of the Melody valve. And the reason for this is, if you can see over here, is to extend the lifetime of these conduits, because often these conduits restenose and they leak, so you can actually deploy a stent, relieve the obstruction, and then deploy the valve within the stent. There are over 500 patients, probably now 700 patients with this valve, over 40 implanting sites. The FDA panel approved, just has voted for approval, but we still haven't got approval, but it has a CE mark, and it's available in Europe and Canada for use. The second valve that's being used is the Sapien transpulmonic valve. It's the Edwards valve. This valve is the same valve that is used in the aortic position, but this is being studied in the pulmonic position. So you can see over here, this is a metallic stent, and this is the bovine pericardium made into 3 leaflets, and this itself is crimped onto a specialized balloon, and then you have a special crimper, and this can be advanced into the pulmonic position. So this is called the transcatheter pulmonic valve. It's a 30-patient study. We've just started to use it. There are only 3 sites in the world: Cedars-Sinai, where I work, Rush, and Duke. And we've only done about 12 patients now with this valve, which is basically the aortic valve. This is the Edwards aortic valve being used in the pulmonic position. And the primary endpoint is to see if there's any device or procedure-related complications at 1 year. So I'm going to show you the example of one of the first patients in Cedars. This is a 53-year-old gentleman who had a Ross procedure. For those who don't know what a Ross procedure is basically you replace the aortic valve with the patient's pulmonic valve, and then you replace the pulmonic valve with a homograft. And so what happened is this patient developed twice restenosis of the homograft within 2 years. And you can see here, this is a severe stenosis of the homograft. So what we did is we treated this patient with a stent. We deployed a Parmaschat stent at 22 millimeter Parmaschats, deployed it, and the stenosis went away, but obviously the patient had severe pulmonary regurgitation. And see over here, this is what it looks like after the stents deployed, severe wide open PR, and then we deployed the Edwards valve over here, and you can see there's no PR now anymore. So we treated this pulmonary stenosis with a stent and then a valve within the stent. So in conclusion, we can say percutaneous transcatheter pulmonary valve is technically feasible and can be accomplished safely without excessive procedure or device-related complication. It's probably going to be effective in restoring and maintaining the pulmonary valve competence. Its relevance is very important for those who will do pediatric surgery and do very complex conduit repair in young children. It is very difficult for these children to have multiple operations. This procedure, palliative procedure, will probably reduce the number of surgeries they can have over time. The next is aortic valve replacement. And as expected, the aortic valve replacement, percutaneous aortic valve replacement, is much larger in volumes. And the reason for that, because it is the commonest valvular heart disease, especially in elderly. And as people with coronary disease grow older, this is the disease that they're left with, and when they get older and they do have coronary disease, they're often very high surgical risk patients. So probably the best alternative is a less invasive aortic valve replacement. And there's therefore a need for this procedure. There are several technologies available, or at least in clinical trials and early phases in development, but the two that are commercially available in Europe are the Cribier-Edwards Sapien valve, and that's basically the first one that I showed you, which is a stainless steel valve, balloon expandable with 3 pericardial bovine leaflets. And then you have the core valve, which is a self-expandable nitinol stent, and within this you have a porcine valve within it. So conceptually, one is balloon expandable, one is self-expanding. Interestingly, both the companies are in Irvine within 2 miles of each other. So they keep fighting with each other. This is being just bought by Medtronic, and this is still owned by Edwards. So the Edwards Sapien valve is deployed on a stent of basically on a balloon, and this is called the sheath, and it's got a cone. And the advantage of this cone is to allow you to go through significant stenosis. But the problem is that you need a 24 French sheath to advance this catheter through. And often patients don't have large iliac vessels to put this in. So that is a limitation of this procedure, that it's a 24 French sheath. As of recently, this has become 18 French, so you can do it. So you can do a transfemoral technique, but if the iliacs don't allow it, what you can do is a transapical technique, and where you actually make, on a beating heart, you make a small incision in the left thorax, and then you advance this balloon with stent assembly, and then you can deploy the valve through a small incision in the apex, and then you can suture it up. The whole procedure is done. It takes about 45 minutes to do the procedure. So I'm going to show you an example. This is one of our first patients that we did. She's 86 years old, severe aortic stenosis. Most people who are 86 years old will be left alone. And then over here, you see what we put a pacing wire. It's very important to do a pacing wire in the right ventricle, and I'll explain to you why. We put a wire across the aortic stenosis, and we balloon dilate the aortic valve with a standard balloon. Once you balloon dilate the valve mounted on this balloon is then advanced across with not much of difficulty, and we position it usually just using fluoroscopy. We're looking at the calcification. And then you'd go rapid pacing. When you go rapid pacing about 200 per minute, you drop the pressure to about 40, you wait for 10 seconds, and then you deploy the valve. And you can see over here, we're just about to go into rapid pacing, and you can see that, and it's almost like ventricular fibrillation, and then it steadies the whole thing. You deploy it in 10 seconds, you deflate, and it's done. So it's a one stop, one chance you get, and there's minor regurgitation, the valve's in good position. People are concerned whether it affects the coronaries. It doesn't usually affect the coronaries because there's a distance between the stent struts and the outer margin of the aorta. This is an example of what would happen. This is the critical aortic stenosis with a gradient of 75, and this is 9 millimeters of gradient just after the valve replacement. So from 0.5 it becomes 2.1 square. This is usually the characteristic that we get about 8 to 10 millimeters of mercury at the end of the procedure. So the trials that have gone on, this is no more ongoing, there are several source registers in Europe, but the one that's just completed in America is the partner trial. It's North America and Europe, which is a percutaneous valve versus conventional surgery, high risk, or medical therapy. And basically the enrollment is completed. And what it is was they took patients with severe aortic stenosis with a valve area had to be less than 0.75 square centimeters. And the STS score was very important that these had to be high-risk people. So they either had to have a score of greater than 10, and this is a very significant risk, or the two surgeons had to feel that they're very significantly risky for surgery. They were then randomized into cohort A or cohort B. Cohort A was those patients who could have high-risk surgery, and they were randomized to either the percutaneous valve, either transapically or transfemoral, or surgery. And cohort B was those patients where the surgical risk was so high, it was to be 50% or more, they could not be randomized to surgery. They were randomized to medical therapy versus the percutaneous valve. So both these parts of the study are over, and we're going to be waiting for the studies, the results to come on next year. In the meantime, there's a continuous access registry which is going on. The other valve is the core valve. That is an 18 French bioprosthetic system, and the core valve is actually similar, but one of the advantages of the system is because this is a self-expandable stent, it's within the sheath, you can partially deploy it, recapture it, and reposition it. This is one of the disadvantages of the first technology. You get just one chance. So this one is at least partially, you can recapture it and reposition. And also, the size of the sheath has gone down to 16 French. So these are the two major advantages of this technology. Here's an example of the valve being partially degreased. We see the positions fine, and then we're gradually releasing the sheath over here. The pigtail is brought back, and then once the pigtail is brought back, you deploy the entire valve. And this is an example to show that you can see the coronary flow is normal, and there's only mild regurgitation, but the valve obstruction is gone. So this is a technology that can be used, which is a little bit more safer in using it. So if you look at the experience of this valve, there's actually close to 10,000 patients done, about 5,000 with Edwards and about 5,000 with the core valve, approximately. I may be wrong on the numbers, but the acute success has gone over 90%. And good midterm results, and the hospital mortality still is about 5 to 10%, primarily because these are very high-risk patients. Two important complications which are related to this procedure is vascular complications, especially with the Edwards valve, and complete heart block with the core valve. Because of the long stent struts pressing on the LVOT, there's a high incidence of complete heart block, especially with the core valve going up to about 20%. So putting this in perspective, we think that aortic valve replacement is clearly a relationship for the future. And then finally, I'm going to go to mitral valve repair, which is my favorite topic. There are two types of diseases: primary disease of the valve, and with prolapse of functional MR. And these can both be tackled by different technologies with percutaneous technologies. And one of the examples, the reason why we do this procedure is because repair tends to be better than replacement for long-term successes. There are several technologies available, but the one that seems to work the best at the present moment is the MitraClip procedure, which is based on the Alfieri stitch, where you actually put a suture between the two opposing leaflets and convert an incompetent single orifice valve into a competent double orifice valve. And this is based on the Alfieri stitch, which is adapted into a percutaneous technology. And you can see over here, you can see this procedure is done transeptally without too much of difficulty. But the beauty is that if it doesn't work, you can take the clip off and remove it completely. So I'm not going to show you the steps, but it's a relaxed atmosphere. No rapid pacing, no arrhythmias. The anesthesiologist puts the patient to sleep and falls asleep himself. Then you do echoes. And these are the two people doing, this is actually the physician assistant, this is the fellow, and that's the guy from the company, and I'm actually reading my email, because you have a lot of time to do this procedure. And here's an example where imaging is important. You can see we can place the clip, it's wrong, and then we correct the position, and then you grasp it, and that's a single, nice double orifice valve with the clip completely closed. Here's an example of a lady with bileaflet prolapse. You can see severe MR. Typical woman from Beverly Hills, doesn't want a scar on the chest. Everyone wants to be an actress. And so here she's got severe MR. You can see wide open MR, And that's it. After just 2 clips, you can see trace MR. Now, you don't always get such perfect results, and this is a patient whose baseline, and that's at 3 years. You can see it's not playing, but you got to believe me, it's actually trace MR now. But the human studies are based on about 731 patients. Basically, this is the first trial, the first registry. This is the randomized phase, and this is the paper I just published in JACC, showing you that the freedom for surgery is about 76% at about 3 years. And this is the most important question that you're going to ask me. What if it fails? What if it doesn't work? And you can show over here, 88% of the patients where the repair did not work either in the beginning or late could have surgery, and 88% of them had the operation that the surgeon wanted to do. So it doesn't remove your surgical options from the patient. So 750 patients, safe and effective both in degenerative and functional MR, not in rheumatic, sustained improvement, and surgical options are preserved. I will not talk about the coronary sinuplasty techniques because there's a shortage of time, but the conclusions are that it doesn't really work that very well in the same sinus. There are other technologies in the sinus working, like the direct angioplasty. They're very early in their phase, so I will not discuss it. So at this time, I just could make my conclusions that percutaneous aortic and pulmonic valve replacement has evolved into a true percutaneous technology, especially for high-risk patients. Mitral valve repair is safe and effective in selected patients, I repeat, in selected patients with non-rheumatic mitral regurgitation, and further improvements in technology will broaden the scope of percutaneous treatment of valve disease. It's truly a treatment affair. I just mentioned Dr. Trento. This is what it changes. He's our chief of cardiac surgery. You can see over here, he's doing a transeptal procedure, as I call him PGY32. It tells you that the surgeons themselves have realized that this is the way to go. And here's an example of that. It is truly a team effort. You need a lot of people, echo, anesthesia, interventional cardiologists, and people in the company. This is one of our first cases. And this is a very famous person. Everybody knows that she actually had a clip procedure. She was on Twitter when she did it. She went 1 month, she went home in 1 day. She's one of the most famous actresses of all time, Elizabeth Taylor. Had the procedure done, went home the next day, and is now out of heart failure. She's still a very sick lady, but it did help. Putting it into perspective, this is not going to be the complete cure, and this is what is reality for us, for percutaneous valve. To cure sometimes, to relieve often, but most important, to comfort always. Thank you very much.